So as I become a more experienced geriatrician, I think I've realized two things. One is we spend all our money in tertiary care, and we should spend a hell of a lot more of it upstream. So I've become much more interested in primary care and particularly in healthy aging. And I think vaccinations are a foundation of healthy aging because, like medications, you get much more bang for your buck in treating an 80-year-old than a 40-year-old because they're much more likely to have a bad outcome like stroke, for hypertension, or atrial fibrillation. So your absolute risk reduction is much better. The trouble with medications is you get more side effects. The beauty of vaccinations is you don't get more side effects. The second thing I've learned is that healthcare professionals actually have a lot of power to influence decisions. And it's very clear with vaccinations, if a physician or a healthcare professional, like a nurse or a pharmacist, really recommends vaccinations, the vaccination rate goes from about 30% to 80%. So that's what I'd like to charge you guys with today is, when you're out at a sports event or a cocktail party or just on the street, talk up vaccinations. We need it. Okay. So I am on some national advisory boards relating to vaccines, and I do some speaking engagements related to vaccines. The bonus mark is, does anyone know what this tree is? Frank, you can't answer. You probably can't remember from 2 weeks ago anyways. I'll tell you later. It's a very important tree that only grows in central Chile and a little bit in central Argentina. So Florence is 80. She's got chronic lung disease, diabetes. She used to walk several times a week with a neighbor, but the neighbor died, so now she just sits around. She manages her meds, but her daughter has to bring her groceries, and we don't know anything about her vaccination status. So seniors are much more at risk for viral disease because of immunosenescence, which is a heightened susceptibility to influenza-related complications in older adults. So you have frailty, but you also have immunosenescence, and that can result in a higher incidence and severity of infectious diseases and a lower strength and a lower persistence of antibody responses to vaccines. So in older adults, generally, vaccine effectiveness is about half that of healthy younger people. So that's the challenge. Vaccines are really good, but we have to find workarounds for immunosenescence. And that's really what the industry is looking at. So with an aging population, you guys know these figures: more family physician, more hospital admissions, longer hospital stays, and vaccines can be very effective. But we don't think of vaccines. Influenza is a big ticket item, and we've certainly seen that in Ottawa in the last year in terms of emergency room visits, hospital admissions, and deaths. This is healthcare spending, and vaccines represent a massive 0.3% of healthcare spending in Canada. And the high-dose flu zone vaccination, which Kathleen Wynne, as a bargaining chip for this election, is offering for free in Ontario to seniors next year, seems like a big deal, but the reality and the irony is it will save the healthcare system money. So she's actually not spending a cent, she's actually saving the healthcare system money, and it would be nice if everyone else did this. The high-dose flu zone vaccination has been out, used, and paid for by the HMOs in the United States for over 5 years. And if HMOs are paying for something, you know not only is it good, but it also saves money. This is the cost per life year saved for vaccines and other public health initiatives. So the crossing control arm for school buses, and we'd never have a school bus without a crossing control arm, costs $410,000 per life year saved. Whereas if you look at the bottom, these 4 vaccines cost 0. And in fact, you save money for each of these vaccines. So it becomes even more of a no-brainer in terms of helping people's health and outcomes, unblocking the system, but also saving money. This is pneumococcal pneumonia mortality rates on the right, hospitalization on the left, and like every other curve you see with the elderly, it's worse as you get older. The biggest risk factor for 99% of diseases is age. So you see this up and to the right phenomenon with practically every disease, and the complications of disease, which include hospitalizations and mortality. And if we look at risk factors, I could give you the same chart for influenza as I do here for pneumococcal. You have immunocompromised physicians on the left, bad behavioral choices on the bottom left, like smoking and alcohol abuse, age over 65, right in the center of things, and then the medical comorbidities. And if you look at those and realize they're all much more common in seniors, especially the old, you can see the double whammy of age, medical comorbidities, and throw in frailty. So this is the risk of pneumococcal pneumonia related to at-risk conditions. And again, it goes higher as you go to the right, but it goes higher as you have multiple at-risk conditions. This is influenza-attributed mortality and the association with chronic conditions. Not only are you more likely to get complications, you're more likely to die. So it's 5 times higher death rates if you have chronic heart disease, and 12 times higher death rates if you have chronic lung disease. And if you've rolled the dice of life and you've got both, you're 20 times more likely to die. So those are people who especially need vaccination. The burden of pneumococcal disease and influenza, we always think of the direct respiratory causes, but the hospitalization that occurs and the iatrogenesis that happens to people who are hospitalized, and then the complications. So the direct effects are on the left here. These are the ones we think of with flu and pneumococcal diseases: asthma, COPD exacerbations, bronchitis, pneumonia, and ear and sinus infections. But it can also be a trigger for acute MIs and strokes, an exacerbation of kidney disease and diabetes. So we talk about the concept of vaccine preventable disability and the concept of catastrophic disability. So that's the straw that breaks the camel's back and someone gets a catastrophic loss of ADLs. And mostly it's associated with hospitalization. But look at the top causes. We always think of stroke and heart failure and pneumonia and influenza. But those top 3, including ischemic heart disease, can all be influenced by diseases that are vaccinatable. This was a study on a meta-analysis actually of 5 RCTs that looked at cardiac events and influenza vaccine. And if you had influenza vaccine, you had lower rates of major cardiovascular events within 1 year. So the rates were 2.9% in the year following vaccination versus 4.7% in those receiving placebo but no vaccination. So that's 36% less. So 1 major cardiovascular event prevented for every 100 persons vaccinated. So this is the burden of pneumococcal disease and cardiac implications. So if you get pneumococcal vaccination, in the next 2 years, your risk of a myocardial infarct goes down by 50%. Something to do with inflammation and plaques is the presumed mechanism. But imagine that, half the rate of MI within the first 2 years after vaccination. Let's talk a little bit about statistics, because I'm sure you all love statistics and remember all your biostatistics courses. So if you're going to practice polypharmacy, at least make it evidence-based. Or how do you take research trials, which are mostly in young and middle-aged people, and extrapolate it to our patients, the 85-year-old? So with increasing age, what happens to relative risk reduction? So these are all the studies you see. New England Journal of Medicine, miracle cardiac drug reduces mortality by 11%. And you say that's pretty good. What happens if you compare 40-year-olds to 60-year-olds to 80-year-olds in relative risk reduction, and everyone gets it wrong? And the answer is there's no change, because there's no fundamental physiologic changes. So in study after study, when you segment out 80-year-olds versus 60-year-olds versus 40-year-olds, there's no change in relative risk reduction. But relative risk reduction is the big cheat in statistics, because it's a bigger number. So you go 11% mortality, but we need to think in absolute terms. So 11% reduction, relatively speaking, is a reduction from 10% to 9%, roughly. So in absolute terms, it's only 1%. But no one's going to get excited about a research article that says mortality is reduced by 1%. But that's the truth in the matter, not relative risk reduction. So the next question is what happens to absolute risk reduction as you go 40, 60, and 80? And this is very easy. The same relative risk reduction is applied against a much higher rate of bad outcomes in 80-year-olds. So they're much more likely to get a stroke, that you can reduce the risk by treating atrial fib or treating hypertension or treating hyperlipidemia. So absolute risk reduction, true bang for your buck, is actually much better in the elderly, which means number needed to treat to prevent one event is much lower. So same relative risk reduction, increased absolute risk reduction, divide that into 100 gives you the number needed to treat. So the issue with medications, as I said earlier, and I say important things twice because they have twice the chance of getting through, absolute risk reduction is much better in the elderly with medications, as long as they're going to live long enough with a decent quality of life to benefit, but you get more side effects. But vaccinations have the big bang for your buck, but you don't have the big side effects. But immunosenescence, which we talked about earlier, says we have to have different strategies. So there's a couple of different strategies that have been looked at for the vaccinations I'm going to talk to you about. So one is pneumococcal strains. And you get a certain number of strains protected against with the pneumococcal vaccination we're all familiar with, which is Pneumovax. But the new one, Prevnar, it's not that new, it's 5 years old, adds a whole bunch of strains. So more strains, better coverage. Strength, Fluzone HD is high dose. It's 4 times the antigen. And adjuvanted, which is the new one for herpes zoster, which is Shingrix, which means you give something that pumps up the immune response. And that's being looked at a lot, not just with vaccinations, but also with cancers. Hence the tree I showed you earlier. So, send in the next 3 patients is for the 3 vaccines that I'm going to talk about. So I'm not going to talk about tetanus. You should have a single booster at age 65. I'm going to talk about influenza, herpes zoster, and pneumococcal. So Pneumovax is PPSV23 and Prevnar is PCV13. That's the number of antigens. And if you look at the two, the advantage of the new vaccine is it's T-cell response mediated, which means you get a stronger immune response and induces much more immune memory. So it's a stronger, better, longer lasting vaccination. And these are the 2 proportions that you see the arrows at the top. And the strains that are covered by PCV13, which is 58%, and if you add the other one, it's 83%. So that's the idea of bumping up immunosenescence by covering more strains. And this was the landmark trial. It's 3 years ago, almost to the day, 17 to the day, wow. So this was a study in the Netherlands because they weren't using the vaccine, so they did the whole country. And what they found was the primary endpoint, which is the prevention of the first episode of pneumococcal community-acquired pneumonia, was down 46%. And the first episode of non-bacteremic, non-invasive community-acquired pneumonia was down 57%. And the prevention of the first episode of invasive pneumococcal disease, which is the one that really kills you, was down 75%. So very, very positive results. And this shows as you go out in time, they're continuing to do this, but the really nice thing is there doesn't appear to be a drop down of vaccine efficacy even after 5 years, which you do see a drop down with the one we're much more used to looking at, which is Pneumovax. And the curves are actually diverging, which suggests probably you're going to get longer lasting immunity as you go with time. So NACI, which is the National Advisory Committee on Immunization, which is an interesting body and generally writes reports that most people can't understand, that may contradict themselves within the same report. Some very well-meaning individuals on it, but their report writing is very strange. And generally they're 2 or 3 years behind the United States, the high-dose flu zone being a perfect example. So their recommendation, there's good evidence on an individual basis to recommend in immunocompromised adults age 65 and older, not previously vaccinated, they should get the 2 vaccines, starting with Prevnar PCV 13 and following with Pneumovax, because you get better results in terms of immunization. So they recommend it for individuals, but then they come around and say, well, should we have a national program? And here's what they say: there is fair evidence to recommend the use in routine immunization programs for adults age 65 and older. So I have great trouble understanding the rationale that it's good for all individual 65-year-olds, but we shouldn't do it across the country as a program. Maybe there's politics and money coming in, which is strange because you get the political goodies, as Kathleen Wynne is hoping to do, but you also save money. So how long do they work? As I just showed you in the Capita study with the diverging curves, you get at least 5 years with Prevnar, and Pneumovax tends to wane, so it's probably sort of good for 3 years and then it becomes less good, and that's the recommendation that you get a booster shot after 5 years. We don't know, do you just keep giving booster shots? But Prevnar looks like at least 5 years out, you don't have to look at a booster. Switching dose to Fluzone high dose. Here's our flu shot report card. The goal is 80% vaccination. For those 12 and over, it's 29%. 65 and over, 62%. Healthcare workers, 53%. Better in long-term care. If we look at individual disciplines, physicians are 59%, 72 if they work in long-term care. Nurses 57, PT and OT 44 and 51, and pharmacists 50, which is pretty stunningly awful to me for people working in healthcare. So we need to do better at individual vaccination and proselytizing other people to get vaccinations. Because the flu shot may not prevent the flu, but it will certainly prevent greater severity and greater bad outcomes. So here's the deal with the flu vaccination. So the vaccinations aim at the head of the hemagglutinin. So hemagglutinin is like little popsicles on a big ball. And you're aiming at the head, and the trouble is the head changes every year. So it's a crapshoot to look at what happens in Australia and Southeast Asia and pick what you're going to put in your vaccination. And the really interesting work being done with flu shots and other vaccinations is the stock, because the stock of the popsicle stick that is, doesn't change from year to year. So if you could get something that worked against the stalk rather than the head, we'd really, really be off to the races. So the virus protection is basically 2 strains of influenza A, H1N1, H3N2, and influenza B. And these are the antibody responses to standard dose influenza vaccination in older versus younger. And you can see the older people are in the yellow, and the antibody response is muted in comparison to the young, immunosenescence. This shows the influenza vaccine effectiveness, which varies somewhat from year to year, and it varies even more in seniors. But you can see the blue line, which is seniors, versus the gray line. They screwed up the gray color there, which is juniors. There, you get much more vaccine effectiveness, around 60% in juniors versus 40 to 50% in seniors. So there's that gap. So with the high dose influenza vaccination, 4 times stronger, no gelatin, no preservatives, no antibiotics, in a big randomized controlled trial with 32,000 people, it was 24.2% better in people over 65. That's pretty good. In people over 75, it was 32% better. So you get 24% in the 65 plus relative improved efficacy. And again, as I told you before, we need to look at absolute. So if we look at vaccine effectiveness of 100 susceptible 65-year-olds who would develop influenza if not immunized, first of all, if all people got flu zone vaccination, it was 30% effective, you'd protect 30 people. 70 susceptible people would develop influenza despite vaccination because of immunosenescence. If you add on the flu zone high dose, you'd get 24% of that 70%, which is another 17 people. So you're up from 30% to close to 50%. So that's the benefit in absolute terms. Effectiveness versus hospitalization or serious events, 6.9% better against all-cause hospitalization, 18% against cardiorespiratory events, and 40% against serious pneumonia events. So again, very solid results, and here's NACI. Based on the available evidence, NACI concludes there is evidence that high-dose TIV, which is flu zone, should provide superior protection compared with standard dose TIV for adults greater than 75. There's another adjuvanted vaccine against influenza, and the results don't support that vaccine in comparison. So the high-dose TIV would provide the greatest benefit, and they basically, in a statement just released, said the same thing as the pneumococcal statement I said, which is it should be given to seniors, but we can't say it should be given as a program. So there's various choices, TIV, QIV, that gets you against an extra influenza B, adjuvanted TIV, and high-dose TIV, and that's the one that's preferred. That's flu zone high dose. So the U.S. experience, as I said, they've been using this for 4 or 5 years in the States. They've given 70 million, this is a year old, so it's now up to 90 million doses, and 60% of adults vaccinated in the United States will receive high-dose flu zone. So that's a fantastically strong number, and I said that's because buy-in by big HMOs is solid because they see the benefits. So this was a study to look again at costs. So the vaccine cost, the difference between the two is $26, higher in Canada, of course. All your vaccines are going to be cheaper at Costco, so that's where you go to get vaccines. Direct medical costs, $73 are saved. So total direct medical cost, almost $50 are saved per person vaccinated. That's a big chunk of money. Total societal costs, if you add in productivity costs, take it up to about $60 per person vaccinated. Effectiveness in preventing hospitalization among nursing home residents, because they are the most vulnerable, and those are the people who get influenza and die. And all-cause admissions are down. Respiratory-related hospital admissions are down. And hospital admissions for pneumonia are down, all statistically significant, and vaccine effectiveness ranging from 8 to 21%. So number needed to vaccinate is 69 residents, would have prevented 1 hospital admission. We're going to turn last of all to the pain of herpes zoster, post-herpetic neuralgia. I remember the first time I ever talked to a group of physicians about Zostavax many years ago, and I finished the presentation, and it was about 25 GPs, and I asked them how many of them were going to get the vaccine, and all 25 put their hands up, because they know how bad post-herpetic neuralgia can be. So the incidence goes up, and if you look at if you live to 80, you have a 1 in 3 chance of having an episode of herpes zoster in their lifetime. And if you make 85, it's 1 in 2. So it's not like it's a rare event. And the real problems are post-herpetic neuralgia, which occur in 10 to 22% of people. So if you make 85, you have a 1 in 2 chance of sometime in your life having an attack of 1 or more attacks of herpes zoster. And this was a study that looked at people to rate how bad pain is. And so increasing pain, and you can see on a scale here of 50, on the right side, HZ, herpes zoster, was about 22, and post-herpetic neuralgia on the left side was 21. If you look just below herpes zoster, for the ladies in the audience, you can see that labor pain is rated at 18. So herpes zoster pain is rated higher than the pain of childbirth. And you can compare it to some of these other issues. So it's bad pain. The shingles prevention study was the landmark study. It's interesting to think it's 13 years ago for Zostavax. And this was a vaccine that has pretty good efficacy in people 60 to 69 at 65%, but over 70 it drops down to 55%. And over 80 it drops down further. So that's again some immunosenescence that becomes a bigger factor the older you get. Hence the Ontario government's totally incomprehensible policy that they'll pay for this vaccination only if you're 65 to 70. Okay. And these are the vaccine efficacy results to prevent post-herpetic neuralgia. And you can see these results stay about the same. So you get some immunosenescence as it relates to herpes zoster, but the rates of post-herpetic neuralgia vaccine efficacy stay at about 2/3. No real waning with age. And this is zoster-associated pain severity by duration score over time in this study. And with vaccination, you tended to have less pain. You may still have pain, but it's shorter and less severe. So the NACI recommendations for immunocompetent adults is recommended for adults over 60, may be used in adults 50 to 59, can be given in people over 50 with a prior history of herpes zoster, but you should wait a year because people can have a second episode of herpes zoster. So this tree is called the soapwort tree, and it's the adjuvant that you see in the new shingles vaccination called Shingrix, but it's also being used and studied in other vaccinations and in terms of drug treatment for different cancers. So it'll probably be all gone in a year because they'll just chop it all down. Okay, Shingrix, so the new vaccine on the block. Waning efficacy with Zostavax, as I showed you there, and if you get over 70, it goes down to about 38%. Shingrix has a vaccine efficacy rate of 97.2% versus 70% in 50 to 59-year-olds with Zostavax. So it's the clear winner. And there's no waning with age. There's only two downsides. One is the cost. It's 2 shots, so it's about $150 a shot versus Zostavax is $150 for 1 shot. The second side effect is you're going to often have a sore arm. And so some people are very concerned about this because you get a greater local reaction in your arm and you can have your ADLs impaired. But basically the duration of this is 1 or 2 days in people who get the worst types of reaction, which are about 10% versus 2.4%. So it doesn't last a long time. So to me, having, a bad day or a bad weekend is definitely worth it in terms of preventing postherpetic neuralgia. So immunocompromised, they haven't done great studies with this, but theoretically, because it's a non-live vaccine, it could be given, but I would really look at this on a case-by-case basis. Zostavax definitely has waning efficacy over time. In Shingrix, sort of like the ones I showed you with Prevnar in the Capita study in the Netherlands, 4-year efficacy is still 88%. So it's hanging up there pretty well. So prevention of postherpetic neuralgia, Zostavax still buys you 67%, but Shingrix buys you about 90%. And I talked about the grade 3 local reaction and systemic reactions, but they're short duration. This was efficacy in all age groups. So on the left, you see 70 to 79, 91% vaccine efficacy, and the same for people over 80. So it works even in the old. And this is going out 4 years, and on the right-hand side, it goes year 1, 2, 3, 4. You're going down only by about 9% over 4 years, and those studies are ongoing to see how long out it goes. But I suspect Prevnar and Shingrix will probably top out 10 years. This is the local grade 3 adverse reactions I talked about in terms of pain and redness and swelling, and this is systemic. These are really low numbers, and they don't last very long. So the median duration of grade 3 myalgia or muscle pain is 2 days. The median duration of shivering, fatigue, GI upset, and headache is 1 day. Short-term pain for a long-term gain. These are the basic costs. The most expensive by far for seniors is Shingrix because it's 2 shots. As I said, exhaustively searching across the region, you should go to Costco. You're going to get the best deal. And just to finish with the second point I made when I started, which is the first point was vaccines give you more bang for your buck without side effects. But the second point was the influence of healthcare professionals' recommendations in terms of getting the pneumococcal vaccine or the tetanus shot or the flu shot. We have a lot of power to influence. And remember, the more people who get vaccinated, this concept called herd immunity kicks in, which is also more protective, very important in the nursing home. So get out there and tell everybody to get vaccinated. You should vaccinate all patients over 60 to 65. The approach in a family physician practice may be to pick off the higher risk people. So that would be people over 80, people who are frail, or as I showed you, the multiple comorbidity at-risk conditions. Because you probably know these people pretty well if they're your GP, because they're the ones who are spending lots of time in your office. And they're more likely to understand the risk. What's the role of geriatrics? I think it should be for really, really advocating for vaccination. as individual geriatricians, when we do teaching or see patients, but also as the society, the Canadian Geriatric Society, and other geriatric societies in Canada, OTs and PTs and pharmacists, should be playing a strong role in advocating, because this is a very positive measure for your senior patients. Thank you very much.